Respecting Client Choice and Its Effect on Treatment by Crystal Rhines. Client choice has long been challenged in the treatment field. There's always been a dilemma of when somebody is able to make decisions for themselves and when they need help in terms of having set treatment plans or having guardians appointed for them. Having that limit defined of when they are able to make the best decisions for themselves can be difficult, and it can be debated in agencies, the court system, and other settings. My paper talked about how allowing individuals to take part in the planning of their individualized treatment allows them to be better engaged and confident in their care. The field of behavior analysis has different ethical guidelines that we follow. According to Bailey and Birch's book, Ethics for Behavior Analysts, the behavior analyst has a responsibility to operate in the best interest of our clients. So that means we need to keep in mind the best decisions in terms of treatment methods and individuals involved. This can be challenged when an individual in care tries to make decisions for themselves that the behavior analyst does not see as the best decision, and they may not be able to be fit. It can be magnified when they have been diagnosed with a developmental disability or a mental illness. So we need to keep in mind that the clients have a right to have a choice in their treatment. The dilemma comes into play when individuals diagnosed with developmental disabilities or severe mental illness are trying to take part in the planning of their treatment. Deciding what the line is of when they can make decisions on their own and when they need help is what's caused dilemmas with treatment teams. What we need to keep in mind is that the clients have a basic right to have a choice in their treatment, and they also have the right to be part of the least restrictive treatment environment. Another ethical guideline that can be used in the client's right to choice is the guideline discussed in our Fisher book, Decoding the Ethics Code. This code states that the client must receive treatment plan that is beneficial to them. This is important because it can be determined as beneficial from a clinical standpoint by the behavior analyst, but we need the clients to be on board too because this is their treatment, it's not our treatment. This guideline also explains that if a client is not engaged, they will not respond in a positive way to the prescribed treatment. My viewpoint on client choice and treatment is that it is needed, necessary, and ethical. I've already discussed some of the ethical guidelines, but I think it's needed to help them feel comfortable with treatment. It lets them know that their needs are being heard, which kind of validates what's going on for them. Seeking treatment is a big step, so knowing that their needs are validated and that somebody is listening to what they want help with can really build rapport. It's also lets them know that they can feel confident in the therapy process and that they understand what's going on, so they will go along with treatment. It's a basic right, and we're not in therapy for us. We're not in therapy for the help. The clients are in therapy. It helps us gather more information for the therapy process, as the client is more likely to self-report if they feel confident, and it also increases engagement and decreases the likelihood of client dropout. I had a personal experience with client choice being challenged. I worked in a residential facility with a 20-year-old male with a diagnosed developmental disability. Although he was living in a residential setting, he was extremely high functioning. He could complete his ADLs without prompts from staff, so was able to shower, maintain and clean room. He also had a job that he went to 5 days a week, and he could communicate his wants and needs to both peers and staff. He was doing very well and wanted to get his own apartment and be in a community-based program and have outpatient counseling. The treatment team felt this could be effective, but the social service director was not really sure about it. After a long debate, the executive director of the facility made the determination he could live on his own. He received extra treatment on maintaining an apartment and cooking meals. He moved out and was able to live independently and was successful at doing so. One of the most famous court cases is Olmsted versus LC. This is when two women, Lois Curtis and Elaine Wilson, who both had developmental disabilities and mental illnesses, were admitted to a hospital. After their treatment was complete, they were determined to be stable enough to live in community-based programs. However, they remained in the hospital for multiple years. On June 22nd, 1999, the court decided that the hospital partook in unjustified segregation of the women as they had disabilities. The judge decided that they should be able to live in community-based programs if services are appropriate, if they don't oppose it, and if they can be reasonably accommodated. The Supreme Court also decided the institutional placement of persons who can handle and benefit from community settings perpetuates unwarranted assumptions that persons so isolated are incapable of or unworthy of participating in community life. A local case is one that took place in Belleville, Illinois, so that's not far from here. It was between the TDL group and Greenmount Manor subdivision. The TDL group was moving individuals with developmental disabilities from a larger group home setting into a smaller setting, and they wanted a more residential home feel. 30 individuals that lived in the subdivision protested this to Belleville City Council. Due to the conflict, the individuals remained in their larger group home. The subdivision determined that they did not want the clients there. However, it was proven to be a more beneficial placement for them as they could be more integrated in the community and it was closer to some of their jobs. This was going to be followed up at a later city council meeting to see if TDL Group could obtain the proper permits. One of the biggest laws involved is the Americans with Disabilities Act. This was developed by Senator Tom Harkin and signed into law by President George Bush on July 26, 1990. The overall point of this law is to help individuals with any disability avoid discrimination based on their disability. This law was cited in the Olmsted versus LC case, and the fact that the second title was violated and that the clients were held in a more restrictive setting than warranted. So what causes the dilemma of client choice? Many people have personal beliefs based on experiences or something they've heard about, or some people have beliefs based on their upbringing. Another dilemma is coming from the media and social media in terms of things that people see in movies or they see on TV or they see on Facebook. A big one I noticed was when there was the Sandy Hook shooting and it came out that the shooter had Asperger's. I noticed kind of an uproar about kids on the autism spectrum. And same goes for the Aurora, Colorado shooting. The fact that the shooter was deemed psychotic at the time, people kind of, the stigma of mental illness already was bad, but it kind of caused more of a public panic, and people don't know how to interpret what's going on and how to get the people the proper help without just completely institutionalizing them. So the research says that the clients have the right to habilitation, which means the skills needed to live as independently as possible. So choice can be withheld by clients having little or no input in decisions regarding their treatment. So this is when sometimes people step more into the caregiver role instead of working with the client. With staff teaching behaviors with little or no regard for the client's preferences, choice not being taught, not giving the opportunity to choose. So that's what leads to a power imbalance between the behavior analyst and the client. When choice is offered, clients prefer situations in which the choice is given. They appear to participate more in treatment and have a less likelihood of dropout. Their task performance increases, problems, behaviors decrease. They report less discomfort. It holds the client responsible for their behavior, so it makes them more active instead of passive in treatment, and they have better self-reporting. With their self-reporting, this would be identifying feelings and behaviors they are experiencing. In terms of the research, there are not many studies out there, so there is kind of a lack of research. Another limitation is that a lot of the studies were completed in more of a laboratory setting instead of a natural setting, which can make it hard to measure a client's behaviors in what they would do in normal everyday life. There's many legislation parts involved. There's the Declaration of Rights of Mentally Retarded Persons, that was in 1972, the Developmental Disabilities Assistance and Bill of Rights Act, which was in 1979, the Community Mental Health Centers Amendments in 1975, and the United States Constitution. And empowerment is the ongoing capacity of individuals or groups to act on their own behalf to achieve a greater measure of control over their lives and destinies. This is important as we want to empower our clients to be more independent and to take their treatment on.